Marina Garcia-Prat from Pediatric Infection Diseases and Immunodeficiencies Department at the Hospital Vall d'Hebron.
Good morning, everyone. My name is Marina Garcia. I'm a postdoc researcher in Vall d'Hebron Research Institute. And today I will try to ask this question: can we predict when to evaluate CVID genetically? So first of all, let's talk about CVID. CVID stands for Common Variable Immunodeficiency. It is one of the most common inborn errors of immunity and is classified in group 3, predominant antibody defects. Patients with CVID are characterized by having hypogammaglobulinemia and poor response to vaccines. As its name suggests, it's variable in clinical presentation, age of onset, and severity. The main clinical features are recurrent respiratory infections, immunoderegulation disorders, and lymphoproliferation. Although it is considered as a non-monogenic entity, in a low fraction of patients, a genetic cause is detected, and then the patients are no longer classified as CVID and are diagnosed with their genetic defect. Those patients receive immunoglobulin therapy for life, and a rapid diagnosis is needed in order to initiate treatment before the development of complications such as bronchiectasis. So the hypotheses of our work are that an approach using NGS allows the identification of a subcore of patients with a monogenic defect with a potential application of a targeted treatment, as well as genetic and preconception counseling for patients and relatives. Also, that the evaluation of clinical and immunological parameters allows to determine in which subgroup of CVID patients is necessary to prioritize the genetic study. Our main objectives are to determine the percentage of monogenic forms and causative genes in a cohort of patients diagnosed with CVID, and to determine the clinical and immunophenotype of patients most likely to have a monogenic defect that indicates the need to perform a genetic study at healthcare level. So a cohort of patients diagnosed with CVID was created, most of them from Vall d'Hebron Hospital with a small representation from Baby J Hospital. And all of them met the diagnostic criteria proposed by the ICON, published in 2015. All the data was collected regarding demographic information and clinical manifestations, and thanks to the biobank from our hospital and with the extraction of 3 tubes of blood, we were able to perform advanced immunophenotyping of B lymphocytes, NGS, molecular studies, functional studies, and the detection of free light change in serum. All the data was statistically analyzed thanks to the statistics service in the Societat Autònoma de Barcelona. So finally, we were able to create a cohort with 136 patients. Most of them were adults, 90% of them were adults, with a small representation of pediatric patients, in 10% of them. Regarding gender, we observe a balanced distribution. We see 54% of male and 46% of female. We just observed 2% of consanguinity in our cohort, and the most frequent ethnicity was Caucasian, with 2 patients from Latin America and 1 patient from Asia. Regarding clinical manifestations, we observed that 91% of patients from our cohort suffer from recurrent respiratory infections, 83% suffer pulmonary involvement, 76.5% had gastrointestinal involvement, 45% lymphoproliferation, 27% autoimmunity, and 7% neoplasias. So the results of the B lymphocyte immunophenotype show that 85% of our patients had normal levels of B cells, and 58% of them had normal levels of switch memory B cells. What was surprising to us was that 64% of the patients present high transitional B cells, and 86% of the patients present normal levels of CD21. The results of the serum free light chains show that 79% of the patients have a decreased free kappa chain, and 82% of patients have a decreased free lambda chain. Overall, an 83.9% had one or both subtypes decreased. So after analyzing our genetic results, after doing the NGS, we were able to see that 26.47% of patients present relevant variants related to CVID. These variants were a total of variants of 36 in genes such as TACI, NF-kappa-B1, LRBA, PAK3R1, BTK, Icaros, RNU for attack, NEMO, CTL4, and DKC1. In this figure at the bottom, you can see the distribution of the TACI variants, and we established causality in all the variants that were biallelic, so the homozygous and compound heterozygous, and we consider variants of risk all the variants that were heterozygous. So in order to validate all the variants that we found with our NGS studies, we perform some functional and molecular studies. For example, in LRBA cases, we perform flow cytometry with intracellular staining of LRBA. For Icaros cases, we perform RNA sequencing and NGS in different tissues and different cells. In cases of NEMO, we perform Western blot, cytokine production, and X chromosome inactivation. In cases of BTK, we perform as well X chromosome inactivation studies. In case of NF-kappa-B1, we perform Western blot and cytokine production. And in one case of TACI, we perform RNA sequencing. With these studies, we can confirm the pathogenicity of the variants that we find with NGS. So finally, we were able to perform 14 family studies, and we find 9 affected relatives and 17 carrier relatives. All of them could benefit from preconception and genetic counseling, and as well as clinical follow-up if they need it. We cannot be able to perform 10 family studies due to the impossibility to contact with the family or due to the non-conformity with the genetic study. So after all the functional analysis and the molecular studies, we are able to confirm that 17.65% of the patients from our cohort have a causal variant of CVID. And among of these patients, we were able to find 8 patients, that represents a 33%, that were eligible to receive a targeted treatment. Those patients are patients with variants in LRBA or CTL4 that could benefit from the administration of abatacept. Also patients with PAK3R1 variants that can benefit from the administrations of sirolimus or seletalizib, and one patient with DKC1 variants that could benefit from hematopoietic stem cell transplantation. So in order to find out if we should prioritize the genetic study in some patients, we perform a study of predictive factors of monogenic forms of CVID, where we confirm all the variables that we collect in our project with the variable genetic variant. And here I show you the 4 variables that were statistically significant, that were age, the age of the patient, the age of onset of symptoms, the clinical phenotype distributed in different groups in infection, and also the levels of the transitional B lymphocytes. All these statistically significant variants were incorporated in a multivariate logistic regression model, where we obtain an area under the curve of 0.87 with a sensitivity of 83% and a specificity of 82%. So in summary, those patients with a higher risk of having a monogenic cause of CVID are those patients with early onset of the disease, with a phenotypic or manifestations with infection and other clinical manifestations, and with high levels of transitional B lymphocytes. So to conclude, a monogenic cause has been detected in 17.6% of cases in a cohort of patients diagnosed with CVID. The criteria that have turned out to be relevant for the genetic study are the age of the symptoms, the presence of other clinical manifestations apart from infections, and the presence of elevated transitional B lymphocytes. The free light chain in serum, kappa and lambda, are a valuable biomarker for the diagnosis of CVID. Having the necessary tools for the functional analysis of undescribed genetic variants or variants of uncertain significance has allowed us to confirm our findings in a significant percentage of patients. Our diagnostic approach has made it possible to carry out the family genetic study and to offer genetic counseling to both patients and relatives. And the genetic study has allowed us to identify patients who can potentially benefit from specific treatments. And just to finish, I would just want to thank my colleagues from the Pediatric unit and my colleagues from Immunology lab, both from Vall-d'Hebron Hospital, and to all of you for your attention. Thank you.
Some question?
So I was wondering, very nice talk. I was wondering what is your interpretation actually of those transitional B cells that are actually elevated in those patients that are basically and that suggests initiation of genetics. Yeah.
We have two hypotheses. The first one is that maybe some transitional B cells are escaping the bone marrow for some reason that we don't know. And the other hypothesis is that in our cohort we have a good representation of APDS patients, that one characteristic of this patient is to have these transitional B cells elevated.
Thank you very much.
Thank you.